Okay, good morning all of you. Today we shall discuss about two charts, one from hematology and one from the respiratory system, the chart 1. Now normally this is kept in the practical exams. These were the charts in the regular basis where we have around 16 charts like this, and each one of you in that particular batch on that particular day, the first half who would come would get somewhere of the 16 charts, and you need to write some points in your answer sheet that day. Same thing, we have put it up online now and we are going to discuss it. Let us just not concentrate on this, and I will be discussing a little bit in the detail about this so that it becomes a little theory revision class for you regarding that particular concerned topic. Now before I start this, there was a pattern where maintaining the social distance norms and other things, if these rules are applicable by the time your practical exams come, it would be something like that the examiners are sitting there on a laptop, and these diagrams or these charts will be put to you online. You have to come in front of the examiner, identify the chart, and there will be a viva regarding this. This may be a pattern. Anyhow, as time proceeds, I will let you know the details, but be ready for the two things. Either you are going into the practical hall, the charts are given to you, the allotted charts, and then you have time to think about it and write a few points on that particular thing, followed by viva. Or it is nothing but the two examiners sitting there side by side, and we decide that some chart has to be put for you. You have to identify the chart, and there will be viva on that, there will be some questioning on that, or you have to describe the graph. So that way the practical exam may go up, but still there is much more time to it, but I am just debriefing you about the procedure that is likely to happen. Now coming on to this chart here. Now if you identify, this chart is a baby because showing that it is a newborn baby suffering with erythroblastosis foetalis. Now what are the features which you see here? The abdomen is protruded, so you will find that there is a protrusion of the abdomen happening. If you palpate or if you feel for the liver, you will find that the size of the liver is enlarged. This is what it is showing, and the protrusion of the abdominal wall is also because there is a liver here and there is enlargement of the liver. So basically a abdominal distension or a swelling on the abdomen with a palpable liver. And here if you see this diagram, it is showing that there is a yellowing of the eyes and there is a yellowing of the skin. Normally the skin should be pink in color, indicating that good circulation amount is going on, but here when there is a yellowish discoloration of the sclera or there is a yellowish discoloration of the skin, it indicates that there is a jaundice developing in the newborn child. Also ultimately this shows that the bilirubin is moving from the circulation into the brain. What does this show? Normally there is a blood-brain barrier. The blood-brain barrier is impermeable to the bilirubin levels, but whereas once the bilirubin level in the serum starts increasing, it indicates that there is accumulation of this pigment bilirubin in the brain, which is known as kernicterus. So this is a baby showing the features suggestive of erythroblastosis foetalis. Now let us go into a little bit of detail that how this erythroblastosis foetalis develops. I'll just take you back to the slides in the blood groups. Now basically the erythroblastosis foetalis occurs because of the presence of an Rh antigen. Rh antigen and HR is related somewhere to Rh antigen and Rh antibody. Let us briefly discuss about the Rh antigen and the Rh antibody. We know that the whole of the human blood group system involves two major blood groups. One is the ABO system and the other is the Rh system. So basically this Rh Rh system is concerned is because of the presence of an antigen which is known as Rh antigen, and erythroblastosis foetalis is concerned with the Rh antibodies. It has nothing to do with the ABO antibodies. So now what is this Rh system? The Rh system is nothing but another classification of blood group where it is the blood group is classified based on the presence or absence of an Rh antigen. If there is an Rh antigen present in the blood, that means that the person is labeled as Rh positive blood group, and if there is a no Rh antigen present, it is known as Rh negative blood group. So this Rh system was first discovered in a rhesus monkey, and it was discovered by LANDSTEINER and Wiener in 1940. Now what does this Rh antigen do? Now this Rh antigen basically induces the formation of an antibody in a person who does not have the Rh antigen. So now there are two types of antibodies, a complete antibody and an incomplete antibody. At your level, for the time being, just remember that there is a Rh antigen. The Rh antigen, if it is present, the person is called as a Rh positive blood group. If the Rh antigen is not present, then it is called as a Rh negative blood group. Now once this antigen gets introduced into the body, it will stimulate the production of an antibody. So there are two types of antibodies known as complete antibody or incomplete antibody. Now let us go back to the Rh antigen and see. Now what is this Rh antigen? Now this Rh antigen is a two groups of antigen where these two groups are labeled as CC, GD and EE. There the D is missing on that particular slide there. Now this two groups of antigens are labeled as capital C, capital D and capital E is one group. The small c, small d and small e is another group. So basically the Rh antigen group is a combination of 6 different antigens which are labeled into two groups, capital C, D and E and small c, small d and small e. So in total this Rh group of antigens is a 6 antigen. Now what is the feature of all these antigens? The rule is that every particular individual will have a particular antigen from one particular group. Let's say for example, the CC group is there, from that one will be present. From the DD group, one antigen will be present. From the other EE group, one antigen will be present. But from one particular group of this CC, both the antigens will not be present. So one from capital C, small c, one from capital D, small e and one from capital E and small e will be present. But both from the same group will not be present. So now among this, what is the features of these antigens? The characteristic feature of this group of Rh antigens is that among all these 6 antigens, the capital D antigen is the most potent antigen and it is likely to stimulate an immune response. Hence, persons who are having this D antigen are called as Rh positive blood group. Those who do not have this D group are called as Rh negative blood group. So again I am repeating these two things. There are two blood group systems. One is the ABO system, one is the Rh system. The Rh system is classified on the basis of the presence of the Rh antigen. This Rh antigen was discovered in a rhesus monkey. If the antigen is present, the person is labeled as a Rh positive blood group. If there is an absence of this antigen, then it is known as a Rh negative blood group. Now splitting this further down, what does this Rh antigen constitute? This Rh antigen consists of 6 different antigens which have been labeled into 3 groups, capital C, small c, capital D, small d, capital E and small e. And in inheritance by the Mendelian laws, one from each group will be present. Now the characteristic feature of all these 6 antigens is, among all these 6 antigens, it is the capital D antigen which is present is the most generates the most powerful immune response. Hence, presence of the D antigen is Rh positive, absence of capital D antigen is Rh negative. Now what is this Rh antigen? Here you can see that this is an Rh positive person because there is an antigen present, Rh antigen, which is binding on the RBC cell membrane. Here you will find that there is no antigen present, hence it is a Rh negative person. Now what does this Landsteiner's law states? That Landsteiner's law obeys, the Rh system obeys only the first part of the Landsteiner's law. And the first part of the Landsteiner's law states that if an antigen is present on the surface of the RBC, the corresponding antibody is absent in the plasma. So what is the Rh system following? It is following the Landsteiner's law, and the first part of the Landsteiner's law says that if an antigen is present on the surface of the RBC, the corresponding antibody is absent in the plasma. That means that if the person has got the D antigen present, that means the person is Rh positive. But the corresponding antibody is absent in the plasma. So for example, if you find that in a ABO system, if you compare with the Rh system, either you will have the antigens of it or the antibodies here. Here only if the antigen is present, its first law states that if the antigen is present on the surface of the RBC body, corresponding antibody is absent in the plasma. It doesn't obey the second part of the law. Now then the next question is, when does this antibodies develop? What I mean to say here is, if a person is having Rh antigen, fine, they will have Rh antigen but they will not have the natural antibodies. But what about those persons in whom the Rh antigen is not present? In persons with a negative Rh group or where no Rh antigens are present, there will be no naturally occurring antibodies. Compare this with your ABO blood group. In ABO blood group, if the antigen is present, then there will be no corresponding antibodies. Then what antibodies will be present? The antibodies are present there where the antigen is not present, antigen is absent. But this does not follow that particular rule. So if an antigen is present, the antibody is absent. But if the antigen is not present in a negative Rh negative person, an antibody will not be present. So the next question is, when will the antibodies develop? So when will a person develop antibodies? If a Rh negative individual is transferred with a Rh positive blood. So here you are doing a mistake. Suppose you are doing a blood transfusion on a Rh negative blood group. You have introduced a Rh positive blood. So what will happen? That the recipient's body will now identify the donated cells as foreign bodies, and they will stimulate the immune system, and the immune system will recognize the recipient's RBCs as foreign bodies and start developing antibodies against the Rh antigen. So this is the way where the antibodies are being developed. They are not naturally present antibodies. The second condition is that where we are now discussing the presence of an Rh positive fetus in an Rh negative mother. Now we go back to our topic of erythroblastosis foetalis. Now what is this Rh erythroblastosis foetalis? Now in this erythroblastosis foetalis, the condition is that the mother is Rh negative, the father is Rh positive, the fetus is Rh positive. Again I am repeating, for erythroblastosis foetalis to happen, there should be two ideal conditions. One, the mother should be having a Rh negative group. The father should be having a Rh positive group. And the fetus should be Rh positive. Now what happens? If such a person undergoes pregnancy for the first time and the fetus is Rh positive, there in the first delivery there will be no problem to the newborn, because during this pregnancy there is a Rh positive antigens are present in the fetus blood. They have been transferred into the maternal circulation during delivery via the placenta, and the mother's immune system recognizes these Rh positive cells which have come from the fetus as foreign bodies, stimulates the immune response and develops the antibodies. So the first pregnancy, in most of the time, there is no problem to the newborn. But if for a second time the mother has a Rh positive child during the second pregnancy, and especially with during the delivery, some of the antibodies would have developed. Some of the antibodies which are already developed as a result of the first pregnancy, now during the second pregnancy will transfer from the placenta into the fetus, and then there will be a antigen antibody reaction in the fetus, and that leads to a condition called as erythroblastosis foetalis. I will repeat this again. The mother is Rh negative, the father is Rh positive, the child is Rh positive. During first pregnancy, there will be no problem to the child because during the delivery, the fetal circulation or the fetal RBCs will cross the placenta and enter into the maternal circulation. This happens for the first time during the delivery, and the mother receives the fetal Rh positive cells. The mother's body recognizes this as a foreign body because the mother is a Rh negative mother, and then the mother will develop an immune response and start developing antibodies against the Rh antibodies, which are Rh antigen, which is present in the fetal cells. So the antibodies are developed in the maternal circulation. Now, during the second delivery or during the second pregnancy, this antibodies which have been developed in the maternal circulation or present in the mother will now cross into the placenta, into the fetal circulation, and these antibodies will start destroying the fetal Rh positive cells. So there will be a antigen antibody reactions. Antigen antibody reaction will be between the fetal RBCs because they are having a Rh positive antigen, and the antibodies which have come from the maternal side, which are Rh positive antibodies, which are Rh antibodies. So this condition is called as erythroblastosis foetalis. It is also called as a hemolytic disease of the newborn. It is also called as icterus gravis neonatorum. It is also known as hydrops foetalis. Hydrops foetalis because hydrops means the head is enlarged, the skull size is much more than normal, the child is much more heavier or more bulkier, hence it is known as hydrops foetalis. Icterus gravis neonatorum because neonatorum means it is a neonate, gravis means happening in the pregnancy, icterus means jaundice. So jaundice during the pregnancy in a neonate is icterus gravis neonatorum, or it is called as a hemolytic disease of the newborn because the RBCs gets destroyed. Now I will explain to you what happens. Now there is antibodies which have crossed from the maternal circulation into the fetal circulation. The RBCs are entering into the fetal bodies. Now within the child, the antigen antibody reaction is taking place. The antibodies are destroying the RBCs. As a result of this antigen antibody reaction between the anti-D antibodies and the RBCs of the fetus, there is a macrophages are coming out, the RBCs are getting destroyed, the destroyed RBCs are releasing hemoglobin. When they are releasing hemoglobin, it is getting broken down, and this is swallowed up or this is taken up by the macrophages. So now the macrophages will start breaking down this hemoglobin. It will start breaking down this hemoglobin into heme part and the globin part. The heme part will be further broken down, as a result of which you will find that there is a RBC lysis taking place. Hence it is known as hemolytic disease of the newborn, because the RBCs are getting destroyed rapidly. There will be a anemia. So the child within the few days after being born will be anemic child. Secondly, since the hemoglobin is breaking down into biliverdin and bilirubin is breaking down into bilirubin, the serum bilirubin in the fetal levels will start increasing. Now you will find that there will be a high serum bilirubin, the skin and eyes will turn yellow, and progressively immediately on the first to second day onwards till the third or the fourth day, you will find that the child's yellowishness of the skin is increasing, indicating that the bilirubin level is increasing. So you will find two conditions: anemia at birth, a rising bilirubin on the day 1, day 2, day 3, or the child is little yellowish on the first day. The yellowishness is seen initially in the eyes and then it is seen all over the body. So jaundice will be present. The third thing will be, because there is a hemolysis which is taking place, anemia is happening, anemia is developing, so the body will try to produce more and more RBCs. So initially this increased RBC production will be taken up by the liver and the spleen. So now the RBC production will start with the liver becoming activated and start producing RBCs, and the spleen also starts producing RBCs. So there will be an increase in the size of the liver and the spleen, and they will become palpable. That is what I have shown you in the chart. A palpable liver or enlarged liver. Also there may be enlarged spleen. So because of the enlarged liver, the abdomen gets little bloated up or becomes swollen. So this is the third condition, where third sign you will find that abdominal distension is taking place. If you put a hand on the abdomen, you will find that the liver is palpable. So that is because of the increased RBC production taking place. The fourth thing which you will find here is that because there is a increased production of RBCs, all the stages of our erythropoiesis are happening very fast. So the bone marrow and the liver and the spleen starts liberating the initial forms of the erythrocytes into the circulation. So you will find that there is a megakaryocytes or megakaryoblast are present, or the pro-erythroblast are also present. So premature or immature form of RBCs will be released into the circulation. So when you see the size of the RBC on a slide, you will find big sized RBCs present. So that is the another feature where immature RBCs are present. The RBCs are enlarged in size because they are not yet matured. Matured RBCs are not there. So this is the other condition where you will find that the size of the RBCs is increased. Now the next condition is, as the RBCs are being lysed, the bilirubin levels keep rising. When the bilirubin levels keep rising, then you will also find that it is entering from the circulation, crossing the blood-brain barrier and entering into the brain. So this bilirubin gets accumulated in the brain parenchyma, and there it starts irritating the various central nervous system CNS organs, and this will result in the development of convulsions or fits. That is because the bilirubin levels crossing the blood-brain barrier, getting accumulated in the various organs, especially the basal ganglion and the other areas of the brain, and then that causing irritation and resulting in convulsions. And such a child can also be born with cardiorespiratory difficulties because there is less oxygen supply to the tissues, so there will be a respiratory distress will be present and the whole body will be grossly edematous. Hence it is called as hydrops foetalis. So this is what happens. Antigen-antibody reaction is taking place. There is a destruction of the RBCs happening. This destruction of the RBCs results in congenital anemia of the newborn. Also, it simultaneously stimulates the bone marrow, liver and the spleen. So you will find that the abdomen is distended, the liver is palpable, the spleen is palpable. You will find that there are erythroblasts in circulation, the premature forms, hence it is known as erythroblastosis foetalis. Also, you will find the same thing, liver and the spleen is getting enlarged, bilirubin is increasing, it is resulting in jaundice, it crosses the blood-brain barrier and results in kernicterus. So this is about the erythroblastosis foetalis. I have told the whole pathophysiology and also explained the basic physiology, the pathophysiology, what is the Rh system, how is the Rh system developed, what happens during the first pregnancy, what happens during the second pregnancy, and in second pregnancy, what are the features which are seen in the newborn. Now the next thing is, what is the treatment of this erythroblastosis foetalis. One is exchange transfusion. What do you mean by exchange transfusion? Exchange transfusion is something like this, where whatever blood is present in the fetus is drained, say around 10 ml, 20 ml in one sitting, and they drain out 10 or 20 ml of blood and give a transfusion of another compatible blood of 10 to 20 ml. So in this way, when you go on giving the repeated exchange transfusions, 20 to 30 ml at a time, or about 5, 10, 15 times in a couple of days, you will be draining out the body of the antibodies which are present, which have come from the mother's circulation. So the antibody titer or the antibody concentration will be coming down, and you will be removing those antibodies from the body of the newborn. So that is exchange transfusion. Now what do you do for prevention? Now prevention is means when you know that there is a Rh negative mother, as soon as the child is born, you get a blood grouping of the newborn done, and if you find that the newborn is Rh positive, you give anti-D immunoglobulins within 72 hours. Now what is the advantage of giving this anti-D immunoglobulin within 72 hours? Now first of all, what is anti-D immunoglobulin? Immunoglobulin is antibody. Anti-D means antigen, anti to the D antigen is anti-D antibody. So now there is one thing which is happening. When you are giving an anti-D injection within 72 hours to the mother, that is after the first pregnancy, when you know that it is a Rh positive child and the mother is Rh negative, after administering these antibodies, what you are doing is you are giving an artificial immunity by injecting the antibodies. When you are injecting the antibodies artificially into the body, it is trying to bind to the antigens which are entered from the fetal side into the maternal circulation after the delivery. So before these fetal cells can stimulate the immune system of the mother to produce antibodies, these injected antibodies are binding to the RBC cells of which have come from the fetus. As a result of which, two things are happening. These antigen antibody binding is taking place. So because of this binding, there will be no reaction taking, no stimulation of the maternal immune system taking place. So there will be no naturally producing antibodies against the anti-D antigen in the mother's body. But what you have injected will get destroyed within 3 to 4 months. So in this way, by giving an anti-D injection, you are preventing the stimulation of the mother's immune system so that naturally developing antibodies are not produced. So that is the best prevention happening. Normally this is done within 72 hours after the delivery, but of late you can give it in 28 to 29 weeks of pregnancy also if you know that the mother is Rh negative. So this will also have a chance that the antibodies may cross there and bind to the fetal RBC cells, thus preventing any movement across the placenta also. So here this is the diagram. There it is the first pregnancy, this is the Rh positive, this is the maternal circulation, delivery is happening. From the fetus you will find that the Rh positive cells are going into the mother, stimulating the plasma cells or the antibodies in the mother. So the mother develops the anti-Rg antibodies. Now this is the first pregnancy which has happened. The Rh positive child from the Rh positive cells from the fetus during delivery crosses the maternal placenta, enters into the maternal circulation. In the maternal circulation, these Rh positive antigens or RBCs will stimulate the immune system, and when they stimulate the immune system, especially the plasma cells, antibodies will be developed. So anti-Rh antibodies are developed. Now these anti-Rh antibodies after they develop will remain in the maternal circulation. Now what happens during second pregnancy? During second pregnancy, this may cross from the maternal circulation into the fetus and develop an antigen antibody reaction, resulting in the development of erythroblastosis foetalis. So here mother which is treated with this Rogam is the name of the antibody injection. What is happening when you introduce this injection there? The RBCs which have come from the fetal side will bind to these antibodies which you have injected. So once there is a binding of these antibodies which have been injected, then there will be no stimulation of the mother's B cells. So this prevents B cell activation and memory cell formation. So this is how the antibodies are developed. How do you develop antibodies? The Rh cells are given, anti-Rh antibodies are developed. Then that Rh antibodies, suppose this is a negative person, you induce the Rh cells here, antibodies are developed, collect these antibodies, store it, and when necessary you give these antibodies into the mother so that they destroy. I think we will stop here. Today for the day we have discussed about erythroblastosis foetalis. In the next class we shall take up the other slides. That is, I will be again back on Monday. On Monday we shall try to discuss some more 2 slides. One of the slides which I plan to discuss here is about on that. Let us finish the respiratory system. We will be talking about the pleural pressure, the alveolar pressure and the compliance of the lungs. Also briefly we will discuss about the lung volumes. Thank you one and all.